Hi, this is Bleeding Control at Protests. My name is Abigail. I'm a Stop the Bleed instructor. This is not going to be an official Stop the Bleed class because they are a little strict, rightfully so, about what they consider to be a class and not. And because this is online, this does not count. However, because it's not official, I do get a little bit of wiggle room in what we talk about. So I'm going to make sure that we touch on some points that I think are really important in the context of protests and street medicine. First off is scene safety. You're going to want to stay with your group or your buddy. I'm going to work off of the assumption that you are going to be with at least one other person in the field. If you're a solo medic, totally cool. Just remember that if you have to transport someone, it is going to be a little difficult to do it with just one person, so you might have to crowdsource or figure something else out. But with your group, you're going to want to always stay with them for safety in numbers. You're going to want to stay alert. The situation is going to change really quickly, and inherently it is an unsafe scene. If you stay alert, you're not only protecting yourself, you're lowering the response time. If you are aware of what's happening around you, you can get gear on, get gloves on, do the things that are going to start the process of treatment a lot faster. So if people suddenly get tear gassed and you noticed that the police were getting ready to do that, you're going to be having a much faster response time and getting people treated quicker. Unfortunately, we've seen it a lot. Your safety is not guaranteed just because you're acting as a medic. By that point, that's kind of common knowledge. But just wanted to touch on it because things like pepper spray and tear gas, rubber bullets, they don't discriminate on your role. You will be in danger if the scene is chaotic, if it's as many scenes have become around the nation. So if possible, you want to stay back from any active conflict and bring your patients to you. That's going to be upwind from any pepper spray or tear gas. That's going to be around the corner or across the street from any of the major conflict. If you have to step forward, step back, just give yourself a little bit of distance. And this is just to ensure that you have a controlled-ish and calm-ish environment to treat patients in and to keep yourself safe in. For personal safety, your safety has to be your first priority. If you're injured, you can't help others and you actually take resources away from other injured people. So do your best not to get injured for a variety of reasons. First off, for your own safety. You want to wear protective gear like goggles, helmets, gas masks, if that's a common thing in your area. Masks, we still are in a pandemic, and medical gloves. If you are treating a life-threatening bleed, you will get blood on you. It's not really so much of an if as it is a when with life-threatening bleeds. Don't let that stop you from treating someone. Just kind of come to terms with it before you go into the field, and keep in mind it's something that you will have to do. It's not really a big deal getting blood on you. You're just gonna, after treatment, after you've passed them off to either the ambulance or the hospital, you're going to want to wash your contaminated skin thoroughly. Even if you can't see visible blood, you're still going to want to wash your arms, and contact a healthcare provider to see if you need to do any blood tests, because there are bloodborne pathogens you have to look out for. Real quick, I want to talk about gloves and glove etiquette. If you are at a protest for an extended period of time, you do not want to be wearing the same pair of gloves for the entire day, however long the protest is, because gloves get micro tears in them and you make the barrier less effective by wearing them for an extended period of time. So this is another thing with the stay alert, right? If you notice something is about to happen, you can put gloves on right before, and that means the gloves are fresher and they're a more effective barrier. Once you're done with the patient, regardless of whether or not you got blood or sweat or tears or whatever on you of theirs, you want to take your gloves off before you move to the next patient. That's just, a common courtesy, and it's also a contamination thing. We don't want to get someone infected with any diseases that another person has. Finally, to protect yourself, I want to talk a bit about how to take gloves off. You have your gloves on, say they're covered in blood. I'm going to pinch, a little pinchy motion, pull that hand's off, ball it up in this hand, hook it under like that, pull it through. You got your nice little bag of bodily fluids, and none on your hands. You're still going to want to wash your hands though. So before we get into the meat of it, I wanted to talk a bit about consent. If a conscious patient does not consent to your treatment, you cannot treat them. You have to ask permission in order to do any treatment on someone. That would look like going up and introducing yourself, be like, "Hi, my name's Abigail. I'm trained to help you. Can I help you?" If they say yes, awesome, begin treatment, begin talking them through what you're going to do. If they don't, you can call 911. That's just going to, maybe hopefully they'll listen to a uniformed medic and be able to get the help that they need that way. If you have an unconscious patient, you can treat them under the assumption of implied consent. Implied consent just means that if the patient was awake, they would want you to save their life. Informed consent is you have permission and you've explained what you're going to do. To me, informed consent means continuously telling your patient what you're going to do, what the next steps are, why you're doing it if you have the time. This is with a conscious patient. Informed consent builds trust and affirms the human dignity and autonomy of your patient. Getting a life-threatening bleed or really any sort of traumatic wound is scary, and it's dehumanizing, and it's a chaotic situation. And by you walking your patient through what's happening to them, getting permission to treat, you are giving them back some of their control and hopefully helping to center them and calm them down. And talking through their treatment helps both of you. If you say, okay, well, I'm going to cut your pant leg off next, you need to grab scissors, right? You can have those steps happening in your head, and that's going to help you kind of keep a steady flow and stay focused on what you're doing. Now for the acronym, we have the ABCs of bleeding control. A is alert, that's alert others about the bleed. B is bleeding, you're going to find the bleed. C is compress, you're going to control and hopefully stop the bleed. I'm going to A, alert first. You want to know your location. That's not just geographically or with street markers, that's also going to be, is there construction happening around me? Is there a police barricade? Where am I in relation to HQ or the base station, or if you have like a centralized setup location, where are you in relation to that? Are you going to be able to get an ambulance to come to you, or are you going to have to go to the ambulance? These are all things to think about. Next, you're going to update your team. That's another reason why having at least two people is helpful. You have someone beginning treatment on the patient after getting consent, and you have the other person contacting team and 911. When you update your team, you can get more people to come to you, which is great if you have to move your patient. And you can maybe get some more experienced medics who may be more comfortable with traumatic bleeds and just generally traumatic wounds, which is a really valuable resource for you and for your patient. I will say if you are contacting over a radio, your team, you're going to want to be a little obtuse about, a little vague about the nature of the injury. So instead of saying like, I have someone bleeding out, you want to maybe consider, I have a severe injury, can I get some more medics over here? That's just to kind of preserve your patient's safety and anonymity in a situation where people might be listening in. And finally, you're going to want to call 911. Your patient does need to go to the emergency room if they have a life-threatening bleed. Depending on where you are, right, you may have to move the patient or transport them yourself, and we'll get into that a little bit later. But best thing to do is call 911. They have some more tools in a more sterile environment than we do out in the field, and they can typically get there to a hospital or trauma center a little quicker than we can. So for bleeding, this is the start of your treatment of your patient. This is the visual assessment. When you see your patient, you either see them go down or you like turn a corner and you see them. you're going to try to find the source of bleed that's going to look like, well, how much blood is there? Where's the blood? A couple indicators of life-threatening bleeds are blood that won't stop coming out of the wound, blood that's pooling on the ground, clothing that's covered in blood, bleeding in a patient that is confused or unconscious, or blood that is spurting out of the wound. If you have blood spurting out of the wound, it's likely that you have an arterial bleed, and depending on the severity of the wound and the artery injured, your patient could bleed out in 2 to 7 minutes. So if you see arterial bleeding, you see some spurting and spraying, you want to get on that patient as soon as possible, because that's what's going to save their life. With bleeding, there's going to be multiple places your patient could be bleeding from. Let's say someone gets shot on the leg and they know that that's there, and they tell you that. You still should do your due diligence and check the rest of their body for other wounds, just in case, adrenaline, they could not recognize that they were bleeding from another location, so you just want to always check. Checking can look like wiping off any excess blood, doing a visual check, doing a tactile check by raking. That's where you take your fingers instead of like the palm of your hand and run it down the arms, the legs, chest, and the back of your patient. Your fingertips are going to catch on any little puncture wounds that be caused by a gunshot or any other smaller wounds that you may not be able to see as easy. Clothing may hide life-threatening bleeding. However, because protests are inherently unsafe, we want to keep clothing on our patient as much as we're able to. You don't want to take off all their clothes if they're only bleeding on their leg. This is just if you take off all their clothes, you're leaving them vulnerable to things like pepper spray and other things that you don't necessarily want. So if someone's bleeding from their leg, pretty much try to only take off as much clothing as you need to treat the wound. It would be like taking their pant leg off, or they get shot in the shoulder or something, you're going to take their shirt off. All the while keeping in mind that there are still things happening around you that make declothing a patient unsafe. Bleeding is going to happen in 3 main areas. That's going to be the blue area, the arms and the legs, which is going to look like direct pressure, wound packing, or tourniquets in terms of treatment, and we'll get into all of those in a minute. The green area, that's neck, armpits, and groin, that's going to look like direct pressure and wound packing, that's the junctional area. And the body, the red area, the chest. There's not a lot that you can do for a patient with a chest wound in the field besides rapid transport and occasionally a chest seal. And I know that that's a really dissatisfying answer, so I wanted to get into biologically why that was a little bit more. The ribs act like shock absorbers, and they make effective direct pressure impossible. So if you're pressing on someone's chest, say they get shot in the chest and you're pressing on their ribs, you're not going to be able to close off the arteries and the veins. The ribs are just going to not allow that. If someone gets shot, say in the stomach area, organs are really slippery and fragile, so they could get more damage by you pressing on them, and there's not a guarantee that you're going to be able to actually compress the arteries and veins enough to stop the bleed. There is one treatment that you can do in the field. It does help. It's called a chest seal. If there's an injury in the upper chest and you can hear or feel air moving through the puncture wound, let's assume it's a gunshot, or there's like a pink froth coming out of the wound, you can use a chest seal. A chest seal is just going to be, here's my gunshot wound. A chest seal is just going to be any piece of plastic, it could be a gum wrapper, literally anything, taped on 3 sides, doesn't matter which sides, but you're going to tape it on 3 sides. It helps the lungs because the change in pressure caused by this new breathing hole can really damage the lungs further. So it won't stop the internal bleeding that's happening, but it will help keep the lungs as intact as possible. And again, it doesn't matter which side you don't tape it on, but only tape it on 3 sides. For a patient with a chest wound, their survival is absolutely dependent on rapid transport to the hospital or a trauma center. You want to make sure that that patient gets there as quickly as possible, because that surgery and blood, that is going to be what saves their life. There's nothing that we can really do in the field besides maybe a chest seal. And if you don't have time to apply a chest seal, don't do it. If you're waiting for more medics to move a patient, or you're waiting for the ambulance, go ahead and apply the chest seal. But if you do not have time, it is not the most important thing. The most important thing is getting them to a hospital. For the C of bleeding control, that's the compression. This is the actual bleeding control. It comes in 3 different key skills and techniques. There's direct pressure and wound packing, and tourniquets. Direct pressure is most effective in shallow wounds. That's going to be if someone trips and falls, or if they get hit with something and the wound's maybe like an inch deep. This is the best method of this. This is for direct pressure, can be applied on the limbs and on the junctional areas, the shoulders and the hips. You're going to use just enough gauze or cloth to cover the injury. If blood continues coming out of the wound, you're going to add more gauze or cloth. You're not going to take it off, because you could be disrupting clotting factors that are doing their work. If direct pressure stops the bleeding, you're going to keep pressing on the wound until help arrives, whether that's in the form of an ambulance or more medics. It is important to note, because again, the situation is inherently unsafe. Protests are fluid. There's a lot happening. If you decide that you are unsafe at the position that you're in, the spot that you're in, you can and should move your patient. You will need several people to do this, and do your absolute best to continue to apply direct pressure as you're moving them. But do your best not to let yourself get caught in an unsafe situation. You're going to want to apply direct pressure as long and as hard as humanly possible. But if you are unsafe, take your patient, move, and then continue applying direct pressure. Wound packing is very similar to direct pressure, except it is for deep wounds. Surface pressure just is not as effective, as you can see in the diagram. A is wound packing. That's where you put gauze or clean cloth inside of the wound. This is great for gunshots, stab wounds, stuff like that. You're going to put gauze inside. That puts pressure on the veins and the arteries, on the tissue from the inside, instead of in B, where you're just doing it on the top. For wound packing, you pack the gauze tightly into the wound until the bleeding stops, and hold pressure until help arrives or you need to move. We are going to be going over direct pressure and wound packing really quickly. See my leg here? This is supposed to be a depiction of an entry hole, and this is the depiction of the exit hole. And then here is a shallow wound. This is what we're going to be using first for direct pressure. The gauze that I have is really weird, long training gauze. Hopefully you won't have to use anything like this out in the field. You will hopefully have gauze or quick clot. Even just clean cloth can work. What you're going to do, we're going to assume that this is a shallow wound. I'm going to do, you can kind of barely see that, let's see. There we go. So we have my shallow wound, patient is horizontal. I'm going to take my gauze, I'm going to put just enough to cover it, and then press in the same way that you would be doing CPR down onto the limb. This is going to hurt. It will hurt your patient, so just keep that in mind and remind them of it before you begin. Next is wound packing. Let's use this exit hole. Wound packing is pretty much the same thing, but just with a little bit extra stuffing. The way I like to do it, at least, is kind of wrap it around my fingers and then stuff it in the wound. It just is easier for me. You're going to take the gauze, quick clot, clean cloth, whatever you got, and stuff the wound as tightly as possible. Stuff it fully. This is vertical because it's easiest for me to show you this way. Hopefully your patient would be horizontal. So once you have full all the way to the top, you're just going to apply direct pressure in the exact same way again, with direct pressure and direct pressure with wound packing. Once you have begun applying pressure, You set up your tent, you're camping there, unless you have to move because of safety. And even if you're moving, you want to keep direct pressure as much as possible on the limb. Just a heads up, there is a graphic image on the next slide. If you have to look away, that is totally okay. So tourniquets, they should only be applied on the limbs, but they can treat a variety of bleeds. They're especially good if you have an amputation or a very mangled limb, where it'd be kind of difficult to necessarily get all of the spots for direct pressure. You don't need a tourniquet to do effective bleeding control, but they can be really helpful sometimes. You're going to want to apply tourniquets over light clothing. So that means like t-shirts, leggings, sometimes jeans, depends on the jeans. But not protective gear like shin guards or arm guards or anything like that. That is just because what a tourniquet does is compresses all the way around the veins and the arteries up against the bone. And if you have protective gear on, can't do that as effectively. Once you've applied your tourniquet, you may need a second tourniquet or direct pressure to stop the bleeding fully. And if you have to put a second tourniquet on, you're going to apply it above the first tourniquet. So that's closer to the body. So it's going to be closer to the shoulders, closer to the hips than the first one. So first, I'm going to talk about, I can find my tourniquet. Here it is. We're going to talk about kind of the anatomy of a tourniquet. This is a CAT tourniquet. It's kind of the standard military one. It's the one that the police carry. It's the one that EMS carries. It kind of looks intimidating to get at first, but I promise it's easy. It has a Velcro strap. This goes around your patient's arm or leg. You're going to want to apply tourniquets on the single bones. So that's going to be pretty much general rule up on the body, as close to the body as you can, at least 2 to 3 inches above the wound. That just helps with compression because it's easier to compress arteries against a single bone than in the double bones of the lower leg and lower arm, just because the arteries typically run through that area and it's harder to compress. So you've got your tourniquet on, you're going to tighten it. This doesn't have to be all the way around. In fact, it shouldn't be. It can just hang loose. That's totally fine. Don't ever cut the end off, because inside of this whole thing there's a cord. It's attached to this windlass. You can kind of see it right there. This windlass and cord is what actually does all of the tightening and will do the bleeding control. So once you have it on, it's perpendicular, set where it needs to be, you tighten this windlass, tighten it, you tighten it, you tighten it until you cannot tighten it anymore and the bleeding has stopped. That's key. It could take 2 turns, it could take 1 turn, it could take 4 or 5 turns, but you are not going to stop tightening the windlass until the bleeding stops. Again, this is also going to be very painful. Warn your patient of it before time. Then you don't have to fasten this, but you can make it nice and neat. And if you have the time and a Sharpie, feel free to write the time. People can go anywhere from 2 to 5 hours, even longer, with tourniquets on with minimal to no damage to the limb. The body has compensations that it can do to deal with the lack of oxygen that a tourniquet, it cuts off the oxygen and the blood flow to that limb. But don't worry about the time. Hopefully your patient should be getting to a hospital before even an hour. Another thing with tourniquets, if you've taken first aid anywhere in the last 5 or 10 years, maybe probably 10, you would know that they've told you to loosen the tourniquet. Don't do that. Once the tourniquet's on, you're going to just leave the tourniquet. It's set, it's there, nothing to worry about. Again, it's not going to harm your patient. It's going to hurt, but it's not going to permanently harm them. So you want to just apply it even if you are not 100% sure that they need it. It's always better. I have my model right here. I'm going to demonstrate how to use the tourniquet. We're going to say my patient's been injured right here. I'm going to slide my tourniquet up. I'm going to do it high up on the arm. I also want to keep it perpendicular to the bone. Bone's right here. I want to keep it as perpendicular as possible. I'm I'm going to tighten it. It doesn't have to be super tight at this point, but you want to get it snug. Oh, I already... Another thing is that these are training tourniquets. It's really loose-y regardless of kind of how much you finagle it. It's going to be loose, so don't use training tourniquets. If a tourniquet's been used, don't use it again. It's just general practice. So once I've got it on, I'm going to tighten and tighten and tighten until the bleeding is stopped. When the bleeding is stopped, I will be done tightening. I will secure it, and then this tourniquet is on this patient's arm until somebody else, either the medics in the ambulance or the surgeon at the hospital, takes it off. But that, you're leaving it on. So to go back over, you're going to apply tourniquets perpendicular to the bone, 2 to 3 inches above the wound. You're going to tighten the windlass, so the little cord, until the bleeding stops. You're not going to place a tourniquet over the elbow or the knee. It's just good practice. And you are not going to remove the tourniquet once it is on the patient. You're not going to loosen it, none of that. If you've put a tourniquet on, it needs to stay on. Improvised tourniquets, that's going to be stuff like bandanas, belts, shoelaces, canvas straps. They take too much time to apply and can be less effective. It is just best practice to do direct pressure or wound packing. So there's always the question, if you're a Boy Scout, to do improvised tourniquets. It is general practice and considered best practice to not use improvised tourniquets. Direct pressure and wound packing are equally as effective if done properly. Improvised tourniquets are things like belts, shoelaces, bandanas that are applied in a similar way that you would tourniquets, but because they're not tourniquets, they often take too much time to apply and can be less effective. And again, a tourniquet is not necessary for effective bleeding control. You can do everything a tourniquet can do with just some gauze and straight arms. Direct pressure and wound packing should be your first choice unless you have a tourniquet with you. You don't want to wait for one. If you are struggling to get direct pressure to work and a tourniquet comes, awesome, apply it. But unless you have a tourniquet on you, you do not want to wait. And an important point that I think kind of goes under improvised tourniquets is don't buy cheap tourniquets. It is incredibly alluring, I know, to get a $6 tourniquet off of Amazon, but those tourniquets are not meant to last very well. They're pretty cheaply made. They can break really easily when you really need them. And if your tourniquet breaks while it's on your patient's arm, you're back at square one. The bleeding has not been stopped. Similar to that, if you have a chance to get your hands on a tourniquet in real life, don't tighten the windlass. If it's meant for use, meant for actual patient use, don't tighten the windlass. Just make sure you know all the parts, because when you tighten the windlass, you weaken the cord. The whole tourniquet is weakened. So real quickly, I wanted to talk about head trauma. With traumatic injuries, there's not a lot that you can do in terms of bleeding in the head area out in the field, but there are a couple signs and just kind of things to do to protect your patient with head trauma and potential brain injury. This is part of your assessment, right? If you see a patient that has a loss of consciousness, they vomited or they are vomiting, they're disoriented, they don't know where they are, or they're dizzy, those are all signs of brain injury, and you should get them as quickly as possible to a hospital or a trauma center. With head trauma, there's always the possibility of spinal damage, and you want to move these patients as little as possible while still staying safe. If someone gets hit in the side of the head, you don't know what that's done to their neck, and by moving them or allowing them to turn their head, they could get more injured. If you have to move someone with a head injury, you want to stabilize their neck by cupping their head in your hands. It's called C-spine. It's going to look like this sort of C, right? 2 C's on either side, and you're going to cup their head. So this part is going to be right behind their ears, and you're going to hold their head like this. If you are moving a patient and you're holding C-spine, that's your job. You have to continue to do that, and you are the one directing the rest of the people moving your patient where you're going to go, because you've got the most delicate part. If someone has facial trauma, that's going to mean like a broken nose or broken jaw or missing teeth, and their trauma is impairing their breathing, you're going to transport them rapidly. Don't try to insert anything into their nose or mouth like an NPA or an OPA, pretty much any artificial airway. That could cause more damage in the field than good. So just keep in mind, if someone is having a hard time breathing because of any injury to their face, they need to get to a hospital first and foremost. Gunshot wounds, this is a scary one, right? Depending on the gun, the wound is going to look different. A good general rule, though, is that however small the entry wound is, the internal damage is going to be greater on the inside. This is because of cavitation, where the bullet moves through the body and it pulls tissue and bone particles and all of that along with it, and creates kind of this cavity that is bigger than the bullet itself. So even if you can see in the bottom picture, the wound is very small, but the damage that is on the inside is going to be a lot bigger because of cavitation. If you do not see, in that same breath, exit wounds are typically a little bigger than entry wounds, but if you don't see an exit wound, do not go fishing for the bullet. You could cause further damage. You don't know what that bullet is holding close, and it's going to be really painful for the patient when you should just be packing, because getting the bullet out is not really going to do a lot for them in the field in that moment. When they get to a hospital and they get to a trauma center, it will get taken care of there. It's a good general rule for anything that is in someone else's body that's not supposed to be, right? If you have a bullet, or you have somehow someone gets impaled on something, don't remove it, leave it. You don't know what it's holding in place. That could cause a lot more damage if you try to take it out. With gunshot wounds, you're going to want to do wound packing and direct pressure on the junctional areas and limbs. If it's on the chest and it's up high and you're seeing sort of some air movement or some pink froth, you can apply a chest seal. But with any sort of gunshot wound, you're going to try to get that patient to the hospital as rapidly as possible. If you're treating a patient with life-threatening bleed or head injury, they should not be given water. I know it's hot, summer, it feels just awful outside. Even if a patient asks for water, do not give it to them. Drinking water can increase their risk of vomiting or water getting into the lungs, and the body won't be absorbing the water anyway. Another thing is you want to keep their system as clear as possible in case they have to go into surgery. Another thing, especially in the summer, you want to be conscious of where your patient is laying down. A good general rule is if you would not want to lay down there, maybe don't make your patient lay down there. If it's on hot metal or in the middle of the road, or unlikely for this time of year, but in snow, these are all things to consider. You want to keep your patient as comfortable as possible. Keep them in the shade. You don't want to get a sunburn and also a gunshot wound. If the body is doing a lot of compensatory things, so you don't want to make temperature regulation another thing that the body has to do. So try to keep them at a pretty constant temperature. Don't use ice or anything like mist or fans to cool them down. Just kind of keep them at a constant temperature. Shade. If they're super overheated, do your best to lower their temperature while not doing extreme things like put ice on them. If you're in a position where you have to transport your patient, that means getting an ambulance would be slower than taking them yourself. I've noticed that's something that's been happening, not regularly, but enough that I wanted to talk about it around the country. There's a couple things that you can do to kind of help yourself and your patient get through the transport. Transport's going to be painful. It's going to be a lot of jostling. You're going to want to monitor their general status. It's going to be their level of consciousness, their breathing, the strength of their pulse. You can check pulse. You can feel it on your own with your middle finger and your index finger, your pointer finger up against your neck. You can feel your pulse. That's a place where you can check your patient's pulse. You don't need to get their pulse rate. Just kind of see, is it fast? Is it slow? Is it strong? Is it weak? These are all kind of things that can help you identify where your patient is at in their decline, because if they've lost a lot of blood, they will be declining, and the question is just how fast. If your patient is conscious, keep them talking. This should be something that you're doing throughout the entire process. You're going to be telling them what you're doing, trying to get relevant information like their name, any allergies they may have. This could be their blood type if they know it. That's really helpful stuff that the hospital makes the hospital's job a little easier and quicker. Another thing is you're going to want to check to make sure the wound has not started bleeding again during transport and the jostling. If you're doing direct pressure and wound packing, you should still be applying direct pressure in the vehicle and as you're moving anywhere, but you might need to add more gauze or start direct pressure with a tourniquet just because of the movement. Lastly, I know it's corny, but believe in yourself. When you believe in your abilities, when you believe in your skill as a medic, you become a more effective medic. When you learn effective first aid, trust yourself to do it correctly and stay calm. Your presence raises your patient's chance of survival just by you being there. And as much as I hope that none of you ever have to use any of the skills, any of the bleeding control skills that we went over today, thank you for watching and stay safe out there.